Hello and welcome to Third Eye Medical Education. Today we'll talk about this important topic called as membranous glomerulopathy. Now this is a nephrotic syndrome, which means there will be plenty of proteinuria. In fact, this is the most common cause of nephrotic syndrome in adults. If you recall, the most common cause of nephrotic syndrome in children is called as minimal change disease. Now just like any other nephrotic syndrome, this is a slow onset disease. It could be either primary or secondary. Now this is an important high yield topic that you need to know. The primary could be because of what is called as anti-phospholipase A2 antibodies, which can be abbreviated as PLA2 antibodies. So this is very high yield because this is often tested, and what I have done is I have marked the high yield stuff with this kind of asterisk. And these are the things that will help you in answering the questions. Secondly, these are also the points on which you will be tested. It could be secondary to systemic diseases like systemic lupus erythematosus, diabetes mellitus, or solid tumors like carcinoma of the lung or colon. Infections like hepatitis B virus, hepatitis C virus, syphilis, and malaria can cause nephrotic syndrome due to membranous glomerulopathy. Drugs can cause nephrotic syndrome, and these include NSAIDs, penicillamine, and gold. Now let's try to put things in perspective by solving this case. So we have a 52-year-old male who comes to the clinic with sudden onset, so there is something acute happening, of right flank pain and hematuria. He has been recently diagnosed with idiopathic membranous glomerulopathy with classic features of nephrotic syndrome. So they have made your job easy. They have already given you the diagnosis. So obviously the question is going to be related to something else. So he is regularly taking telmisartan and hydrochlorothiazide, and his blood pressure is now well controlled at 128/82. His pulse rate is 82 and edema has subsided substantially. Clinical examination reveals a right-sided varicocele that he has not noticed. Urinalysis shows RBCs and proteinuria. Serum lactate dehydrogenase levels are high. Now the question they're going to ask you is urinary loss of which of the following is most likely the cause of his acute symptoms. Now his acute symptoms are sudden onset of right flank pain and hematuria, which is going to lead to RBCs and proteinuria, high LDH levels, and the right-sided varicocele. So you have to choose between the options of albumin, hemoglobin, lipoproteins, antithrombin 3, immunoglobulins, and calcium oxalate crystals. Now, if you intend to think through this question, you can pause the video, answer it, try your luck. Until then, I'll proceed and solve it for the rest of them. So the correct answer is D, antithrombin 3. And this is because there is increased permeability of the glomerular basement membrane in any nephrotic syndrome. This is because of damage to the podocytes, and this damage to the podocytes and the glomerular basement membrane will lead to loss of proteins. Albumin is something which everybody knows, but in addition they can also lose other proteins like anticoagulants. These are the natural anticoagulants in the body, which are antithrombin 3, protein C, protein S, and this can lead to renal vein thrombosis. So this creates a hypercoagulable state, and that leads to renal vein thrombosis. Now if you can recall your anatomy, the testicular veins, they drain into the renal vein, and when this drainage is blocked, it can lead to accumulation of blood in the testicular veins, leading to varicocele. Similarly, a renal vein thrombosis will definitely cause hematuria and flank pain. So this is the loss of antithrombin 3 which is leading to the acute onset in this kind of nephrotic syndrome. The other options that have been listed, they are not known to cause thrombotic episodes. So let's look at the clinical features of nephrotic syndrome, or you can also call this, in this specific instance, the clinical features of membranous glomerulopathy. The most prominent one is very obvious. There's going to be loss of excess protein in the urine, and that will lead to low levels of protein in the blood. There will be edema, and interestingly, there will be hyperlipidemia as well. Now, there will be loss of antithrombin 3, as we just saw, which is a natural anticoagulant in the blood. I have marked this again with the asterisk, which means it is high yield. There can be loss of protein C and S, but less commonly. These will lead to a thrombotic state, which manifests most commonly as renal vein thrombosis or deep vein thrombosis or as a pulmonary embolism. So these will be given to you in the history of the patient, which is also called as the vignette of the question, and you will have to find out what is the correct cause. In this case, it was antithrombin 3. Now, in any nephrotic syndrome and in membranous glomerulopathy, serum creatinine levels are usually normal. However, if it is raised, then it means the prognosis is not good and there is a possibility of thrombosis. So how do we diagnose it? The best initial test, the simplest, urinalysis. This is a very important test, even though it's very simple. And what do you find on dipstick? You find albumin urea. In addition, you can find fatty casts which appear as Maltese cross under polarizing microscope. So you have these casts which are called as fatty casts, and they show the Maltese cross appearance. The second best test is what is called as the spot protein creatinine ratio. In nephrotic syndrome, you should expect this value to be more than 3.5:1. The alternative test could be a 24 hours urine protein, and this will be more than 3.5 grams per day. Now, very often in the vignette, they may not give you very directly that the patient is losing lots of protein. Instead, they will substitute it and say that the patient is losing more than 3.5 grams. Or they'll say that the spot protein creatinine ratio is more than 3.5:1. However, if they ask a question where they want you to choose between the two and find out which one is the better one, then you should pick the spot protein creatinine ratio, simply because the values that are obtained by the 24 hours urine protein is not very reliable, because you have no control of how the patient collects the urine samples every time during the 24 hours. You also don't know how much volume he's taking in, so it is also volume dependent. So the better test would be spot protein creatinine ratio. However, if they ask you what is the most accurate test, then definitely it's got to be the renal biopsy. You don't do this in many cases. However, this is a theoretical exam, so they may ask you what is the most accurate test. Now, under the light microscope, what you see is there is diffuse thickening of the glomerular basement membrane. You can see how it is thickened here. The pink border of this, you can see how you can notice the diffuse thickening of the glomerular basement membrane. However, you can also notice that the cellularity of the glomerulus is normal. So there is no increased cellularity. There is no proliferative change. Both mean the same thing. So in a question where you get both findings, like diffuse thickening of the glomerular basement membrane without increased cellularity, then you are looking at membranous glomerulopathy. If both are increased, which means if there is diffuse thickening plus increased cellularity, then it is not called as membranous, but it is called as membranoproliferative glomerulonephritis. So note this difference, because this is how you will be able to easily diagnose membranous glomerulopathy just by looking at the vignette very properly. In the electron microscope, again, you have a bunch of classic features, and it's called as the spike and dome pattern, where you have subepithelial deposits, which means beneath the epithelium. You will see these electron dense deposits. You can see these dark deposits beneath the epithelium, and this will give rise to the spike and domes. You can see how there are domes and there are spikes. So this is a very classic explanation, which is given again a very high yield point, which will be given as a clue in your vignette. So wherever you see in the vignette that they have described as spike and dome, then it is membranous glomerulopathy. So things like spike and dome, things like nephrotic syndrome, things like loss of antithrombin will all point towards membranous glomerulopathy. Immunofluorescence also has a very typical picture where you will have subepithelial deposits of immune complexes, mostly of IgG and complement 3. So there is a granular appearance on immunofluorescence. The best initial treatment, we look at the management. The best initial treatment is glucocorticoids, again high yield. The second best treatment is to give cyclophosphamide if there is no response to steroids after several weeks of treatment. And there are other therapies which are important. You have to control proteinuria, and that is done very effectively by using ACE inhibitors or ARBs. Edema control can be done through salt restricted diet and diuretics. Hyperlipidemia has to be controlled with statins, just like anything else. Hyperlipidemia, as we saw, could be a major factor in nephrotic syndrome, and this is because the lipoproteins are excreted through the urine, just like antithrombin 3 and albumin, because of GBM damage. Now let's summarize the key points very quickly. The membranous glomerulopathy is the most common cause of nephrotic syndrome in adults. It's characterized by massive proteinuria of more than 3.5 grams per day. Urinalysis will show loss of albumin, loss of antithrombin 3, protein C and S, which may lead to thrombosis of the renal vein. It could cause deep vein thrombosis and pulmonary embolism. There could be hyperlipidemia and lipiduria, which will show as Maltese cross appearance in urine. You can also see lipid casts. Biopsy will show thickening of the glomerular basement membrane, but there will be no hypercellularity. Now this is a very diagnostic feature. It's a giveaway, very high yield. In fact, everything on this slide is high yield. So if you know this slide at the end, you should be able to summarize everything related to this disease. Electron microscopy shows the spike and dome pattern. Immunofluorescence shows the granular pattern. Management is in the form of glucocorticoids, cyclophosphamide, ACE inhibitors, ARBs, statins, salt restricted diets, and diuretics. So before you go to exam, one day prior to the exam, this is the only slide you need to review. So this is the quick review slide which enlists all the key points. Thanks for watching.